evening. My name is Leone and I'm the founder of Freedom From Fistula. I started the foundation about 14 years ago when I had an enormous awareness of the problem of fistula for many women in Africa. From the early days of the charity, we had tremendous support from Rotary, and I'm delighted to say our partnership still continues today. With Rotary's focus in maternal health and childcare, we made a perfect fit, and that still continues to today. Due to the lack of maternal health care for women across Africa, it's estimated that even today, still 1 million women suffer from fistula. That, for example, is the size of Birmingham or Amsterdam, so still a significant problem. Working together, we can help these women and girls and do good in the world today. Before I finish, I would like to say how delighted I am that Gordon McAnally has been appointed the International President for 2023-24. Gordon, we are so happy that we'll be able to work with you. Thank you.
Good evening, everybody. Or as seems to be the case these days as we continue to live our life out on Zoom, good day. And can I add my welcome to that of Dame Anne to this evening's conversation with Freedom From Fistula. My name is Gordon McAnally. I'm a member of the Rotary Club of South Queensferry in District 1020. And as Dame Anne kindly pointed out, I've recently been appointed another role in Rotary. But it's as a keen advocate of Freedom From Fistula that it is my pleasure and privilege to host this evening's webinar. We're delighted that each and every one of you has chosen to join us and to hear something more about what Dame Anne has already said sits so well within Rotary's maternal and child health area of focus. And a particular welcome to Margaret and Ennett, who are joining us live from Malawi. Frightened, abandoned, ostracized, suffering in silence. These are just a few of the words used by an estimated 1 million women and girls across Africa to describe their life, or maybe better, to describe their existence living with an obstetric fistula. A childbirth injury caused by prolonged obstructed labour and lack of access to maternal care. Tragically, the baby usually dies, and the mother is left incontinent, often shunned by her family and community, and condemned to a life of shame, isolation, and despair. Sadly, and all too often, the injury can also be caused by violent rape, often on young girls. As you heard in the video, Freedom From Fistula was established 13 years ago in 2008 to help women and girls suffering from obstetric fistula. It operates fistula, maternal and health projects in Sierra Leone, Malawi, and in Madagascar, and runs the only dedicated fistula care centres in each of these countries, which are recognised as centres of excellence by their respective ministries of health. The charity provides free surgeries to as many women and girls as possible, restoring dignity and quite literally transforming lives. As well as free fistula surgeries, though, Freedom From Fistula wants to reduce the occurrence of obstetric fistula. We all know that prevention is better than cure. And in order to do this, Freedom From Fistula offers free and accessible maternity care, family planning advice for men and for women, education and vocational skills for fistula patients, and free outpatient clinics for children up to the age of 15. They also provide training for healthcare professionals, which strengthens capacity in healthcare systems in countries in which they work. This holistic approach across the whole age spectrum from women in their 80s who have suffered from fistula for decades, as well as to girls, some as young as 5, who are victims of rape. Since 2008, Freedom From Fistula has performed more than 8,500 fistula surgeries, delivered more than 20,000 babies, provided care to more than 200,000 women and children, and trained more than 600 nurses, midwives, and doctors. For many years now, Rotarians around the world working with Freedom From Fistula have offered invaluable support. Most recently, thanks to 3 global grants from the Rotary Foundation, Rotary has funded the training of 60 nurse midwife technicians in Malawi, the purchase of 2 landcruisers kitted out as ambulances, which provide a lifeline for the Freedom From Fistula team in accessing patients in the most rural of areas. And during the past 18 months, over $221,000 was raised to support delivery of free fistula, maternal and childcare centres at Freedom From Fistula's biggest project, the Aberdeen Women's Centre in Freetown, Sierra Leone, where more than 23,000 vulnerable women and children are helped every year. Despite the challenges of COVID during 2020, which, never forget, as a global pandemic affected Africa in a devastating manner, Freedom From Fistula still managed to safely deliver 3,395 babies, perform 219 fistula surgeries, and provide primary healthcare consultations to 18,500 children between birth and the age of 15. I'm a great believer that one of the greatest gifts we can give anyone is the gift of hope. And that is precisely what Freedom From Fistula offers. Freedom From Fistula offers hope for fistula patients by providing surgery and rehabilitation. It offers hope for expectant mothers through the provision of maternity care delivered by suitably qualified and experienced staff. And it offers hope for a brighter future for children who attend the Children's Outpatient Clinic. With Rotary's help, I believe they can do even more. And the great thing is, every single penny donated to Freedom From Fistula goes directly to the projects, as the Globe Foundation covers all of their administrative costs. You will all be aware of the well-known maxim that says, "A picture says 1,000 words." Please watch this short video, which will tell you more about the work of Freedom From Fistula in just a few minutes than I could, where I continued to talk all evening.
The Crew Bay slum in Freetown, Sierra Leone.
I see you too.
Nurse Ami Taliba is here doing outreach for pregnant girls and women.
In terms of every medical disaster, they have the heavy part of it.
These women are in dire need of medical care, facing an almost insurmountable number of life-threatening conditions, from malnutrition and malaria to drug abuse and polluted water.
Across Africa, there's an enormous problem with maternal health. It's pandemic.
The morbidity in women, it's high. They don't do checkups, they don't do pap smears. Women are dying of cancer, hypertension, blood pressure, you name it. They're dying.
We want these people to have their babies alive. We don't want these people to die because of their poor.
If we look at what happens in childbirth and we know that it's fixable, we can do something about it.
The reason that I feel so passionate about this, I think this is an enormous injustice, that these women have got such poor maternity care.
Chief among the concerns for Anne and her foundation is the condition known as obstetric fistula.
Usually what happens if the woman doesn't get to a C-section, then she expels a dead baby eventually. And if the mother doesn't bleed to death, or she doesn't die a couple days later from infection, then that tissue dies.
A fistula is actually a hole, and on this occasion it's a hole that opens from the bladder and sometimes the bowel into the vagina, and then they just leak, so they have no control.
And so instead of being able to hold your urine when you want to, it just pours out.
Most of the women we come across lose their baby at birth. So it's this sad, isolated woman.
They've been thrown out by family, friends, husbands, often they're no longer married, and they have been disempowered as women.
And in Africa, when a woman cannot be a mother, it is harder, because really being a mother makes them confirmed as women. So this is a sad situation. Those are the women we work with.
The reason it's such an enormous problem in Africa is really down to the lack of good maternal health care. It would never happen in the West, because if you were in labour and there was problems, you just immediately have a C-section. This simply doesn't happen in Africa. These women are way out in the bush. They've got no help. They've got no money to get them to help. Even if they had money, they wouldn't find the transport. And when they got to the hospital, there probably wouldn't be a doctor to do the C-section.
In 80% of our patients, we know exactly what to do. There's no mystery to it. And all you need is some decent anesthesia, a table that tilts back, some scissors, and a couple other instruments, and some decent suture. And you can cure that patient.
It is believed that as many as 2 million women suffer from fistula worldwide, and the World Health Organization estimates that it is the cause of 6% of all maternal deaths. While there are many compelling stories, there is none more so than Isatu's.
On New Year's Eve 2011, Isatu was found by one of our nurses on the floor in a hospital.
When we saw her, she was bedridden, completely bedridden, semi-conscious, severely emaciated.
They'd attempted a cesarean section on her, but it was so late, the baby had disintegrated inside her, so she'd become infected. They hadn't closed her up properly. She had a fistula. She had bed sores the size of your fist. The girl was dying.
And when I saw her there, I thought, if we don't get something special to feed this girl, she's just not going to survive. So I went into town and was able to find, after visiting about 20 pharmacies, a box of high-protein mix.
Slowly but surely, they moved her out the ward.
The first time she was able to get out of bed and walked, I don't think there was anybody who wasn't crying.
Why? Because I not be able to do nothing. Nobody not be know for say me baby will get me sick. I don't know for say if I dey live.
Eventually, we were able to help her and do a bunch of surgeries for her, and she's died today, and I'm thankful for that.
These remote rural areas are where most of the fistula cases come from. Venetia lived for 40 years with fistula until she was able to have the operation at Bwaila. Her husband never gave up hope and stayed with her.
Fistula is not just the problem of young girls. We have women come into us who've had fistula for 40 years. That is tragic. Their whole life has just been in misery.
These
women are outcasts. They don't have access to phones and sometimes to radios, so they depend on somebody else bringing the message to them.
There are some areas that it's only by the grace of God that when we go there, we come back safely. Because there are people thinking that, they come with landcruiser. They are being paid big money. So it's really risky, but we love our job. We persist to get the last patient in the last village because we want not only to stop but to eradicate fistula.
For most of these women, a repaired fistula does no good unless they can return to their villages. And for the foundation, this final step in their recovery has been as challenging as the medical treatment is difficult.
Being dry is the first step for the woman because she's able to deal physically with the immediate problem, which was stinking of urine or stool. But it's about her whole healing and her own restoration to the husband, to the community.
We want these women to reintegrate into the community, not the very same woman, should go a different person. So we have lined up several activities that we are doing to really make sure they go back home, not the same.
When they go back to the village, you've got to try and put them back with something that will give them an income for the future. So sometimes we train them in knitting, sewing. So we're always looking for ideas of how we can create an occupation.
We need to empower women, quite honestly, from the bottom up instead of just this top-down approach that we've used in the world.
It's bringing that accountability to them as well as the empowerment. They can decide just to remain as a tomato seller, or they can decide to be the supermarket owner.
When they have economic means, we know that they plow it right back into their family, and it allows them to plan over the cycle of a year. Without working on that holistic approach, we're not going to get where we want as a world for women and girls, and we need to do it.
Health is wealth. Without a woman, there's no society as far as I'm concerned.
Well, I hope you enjoyed, if enjoy be the right word, that video. A video that in essence is about empowering women. And those of us in Rotary this year know how important the empowerment of women is within Rotary International. I'd now like to introduce Lois Boyle, Director of Operations and Communications for Freedom From Fistula. Lois is an honours graduate from St Andrews University and was a founding trustee of Freedom From Fistula in 2008, before joining the charity as part of the senior executive team in 2014, bringing with her vast experience in the communications field, which she gained both here in the UK and in the USA. Alongside her fellow directors, Lois oversees the Freedom From Fistula projects across Sierra Leone, Malawi and Madagascar, providing support to the local management teams in each of these three countries, as well as working with funding partners to ensure the Freedom From Fistula projects continue to serve thousands of women and children every year. Please welcome Lois Boyle.
Thank you very much, Gordon, and thank you to everybody for joining us here. We really appreciate your time wanting to learn more about Freedom From Fistula. Before I hand you over to my colleagues in Africa, I thought it would be helpful to give you a bit of an update as to how things have been for us during COVID over the last 18 months. Due to restrictions within the countries and requirements from the Ministries of Health, we unfortunately had to close our centres in Madagascar and Malawi last April. This was a time of great uncertainty for the patients, for the staff, and for us here. None of us knew in April of 2020 what COVID was going to bring and how it was going to change the work that we could do in Africa. Our immediate priority at that time was to secure the equipment and supplies we had in those centres. And I have to pay great tribute to our local teams who did a sterling effort of clearing out the centres and making sure that all our equipment and supplies were held in secure locations so that we were ready, and we had all that ready to restart as soon as possible whenever we were allowed. And I think extra special credit goes to our Malawian team, who only had about 24 hours to clear our whole fistula care centre. So thank you to them. Obviously then, when we closed, we had in those two centres, we had the staff to consider and what was going to happen with them. So, as I said, a time of uncertainty for all of us. So the decision was taken that we would continue to employ the staff, and we supported them with percentages of salaries and bags of maize flour every month to help them feed their families. And we did that throughout the time that the centres were closed. Thankfully, the Aberdeen Women's Centre in Sierra Leone was able to be able to remain open for our essential services. So our children's clinics stayed open throughout COVID and has continued. Our maternity unit has stayed open throughout. And our work with child and adolescent rape victims has also continued throughout COVID, which is very important to us for those who are injured to be able to come to us and seek treatment. Unfortunately, we did have to close our fistula service in Sierra Leone and suspend that, and also our wraparound support services for our teenage mothers. We have some additional projects that support young teenage mothers once they've had their babies. The biggest challenge in Sierra Leone was PPE. Initially, that was the biggest challenge. I mean, that was a challenge right across the world, but Africa certainly wasn't a priority for suppliers. And we remain enormously grateful to donors who donated PPE, as well as supporters who agreed and allowed us to redirect their funds to the COVID response in Sierra Leone to keep open the Aberdeen Women's Centre. And thankfully, these many, many months later, things have become easier, but we still have all the COVID measures in place that we still need to fund, triage nurses and PPE and cleaning supplies. The impact of our 3 fistula centres being closed was significant in all the countries where we work. And for example, in Malawi, by the time we reopened, we had a backlog of 400 patients on a waiting list. And that is true across all the countries where we work. But I am pleased to say that we have reopened all of our centres. Malawi reopened in April, Madagascar reopened in May, and the fistula service at the Aberdeen Women's Centre was able to reopen at the end of last year. So far this year, we've been able to provide 350 women and girls with free fistula surgeries, and we are working very hard to work through the backlogs in each of the countries. We do have to continue to work under COVID protocols. So we haven't been able to maximise the number of patients through our centres as we would do normally, but we are getting there, one step at a time. Before I hand you over to my African colleagues, I thought it was important to say something. What I think is really important to share with all of you is we are not trying to be Western hospitals and clinics in Africa. We are trying to be the best hospitals and clinics we can be in an African setting. And I think that's really important. We employ, train, upskill local staff, national staff, to ensure that the projects are sustainable in the long term. And I'm very pleased to say that in Madagascar and Sierra Leone, over 95% of our staff are national staff. And in Malawi, it's 100% of our staff are national staff, which is great testament to everybody who works across our units, and also really is an ethos that comes right from the top down within our organisation. So that's enough from me. I'm going to hand you over to the real stars of the show tonight. First of all, we have Margaret Moyo, our country director in Malawi. Margaret has been with us since the very beginning when we started in 2010, and she's overseen the growth of the Malawi project from, I think, 62 surgeries in year 1 to nearly 400 every year going forward. And then we also have Dr. Enit Chipungu, who is our Malawian medical director and lead fistula surgeon, but she's also been our clinical director in Sierra Leone twice. So we've asked her to join us tonight from Malawi with Margaret so that she can also speak about our work in Sierra Leone, which and Malawi and Sierra Leone have been fantastically supported by Rotary, of which we're exceptionally grateful. So I'm now going to hand you over to Margaret and Dr. Enit. Thank you.
Hello. Hello. Warm greetings from Malawi. My name is Margaret, as Lois said already. I've been in the program since 2010. And in fact, the Fistula Care Center was launched in 2010. We are located at Waila Maternity Hospital, one of the busiest maternity in the country. That's where we are. We have a 45-bed facility solely dedicated for fistula management. and we also have a dedicated theater. We have a capacity to treat more than 400 women every year. And since we started in 2010, we have done more than 3,200 surgeries of fistula. And we have also screened about 6,000 women. The center generally receives women from all over the country. At first, we used to get a lot of them from the central region, but later we had to get patients from all over Malawi, including the border countries of Mozambique and Zambia. Malawi's maternal mortality rate is estimated at 439 per 100,000 live births. It's a very big problem in Malawi. And every woman that dies, about 15 to 30 others survive, but they end up having major disabilities. And one of the severe disabilities is obstetric fistula. So as a center, we dedicate ourselves to repair these mothers with fistula. We have about 44 members of staff, and some of them are the former patients, and we did that for a purpose. Out of the 44 members of staff, 10 of them are survivors, patients that we treated. They've been recruited solely to become role models, but they also help to restore hope for those that have not yet been repaired. They do such an amazing job. It was already explained that fistula comes in because of prolonged obstructed labor. Yes, in Malawi, women die due to prolonged obstructed labor. And many of them end up having the obstetric fistula. As a facility, our main aim is to make sure that when these women report to the center, they are repaired. We have very dedicated staff that work round the clock. Before the patient goes to theater, we really make sure that all the investigations are done. That is the hemoglobin. We even look at the nutritional status. We also start counseling them to really understand what type of operation will the patient undergo, and just to make sure they consent for that. After repair, the women are cared very well with the dedicated staff. We've never had any death of a patient after operation. This is because they are closely monitored. They have to check the patient is not bleeding. They have to make sure they are controlling the pain. The patient is draining, because usually after theater, the patient has the catheter. So they have to make sure that the patient is draining. Let me talk about the prevalence rate of fistula in Malawi. Some studies have revealed a prevalence of 1.6 per 1,000 women. And it is also estimated that there are about 20,000 women living with fistula in Malawi. And according to the Demographic and Health Survey, which was conducted between 2015 and 2016, it revealed that about 43% of women aging between 19 to 49 years have heard about obstetric fistula. So it remains a major health problem in the country. Let me talk about the major predisposing factor in Malawi. First is the early childbearing. There's an adolescent birth rate of about 152 per 1,000 women. And 25% of teenage aged between 15 to 19 years have already started childbearing. And we're even witnessing this at the facility right now. We are getting very young mothers with fistula. And it's sad even to learn that they are delivering at home. We know that maybe because of the COVID, in Malawi, people are afraid to go to the hospital because they are afraid they will get the COVID vaccine. So we are experiencing lots of home delivery with fistula. And the other reason is inadequate use of skilled attendants at birth. Inadequate access to emergency obstetric fistula care services is also another contributing factor, and the weak healthcare system that failed to provide a continuum of vital maternal health care services. So it's a major challenge in Malawi. It also shows the need for universal access to maternal care services, particularly emergency obstetric care and the skilled birth attendants. Those two are very vital. And it also highlights issues of poverty and equity. So in Malawi, fistula really is for the powerless and the poor women, and it is an issue of right. So these women were at the center, especially when they are arriving on admission, they are really very miserable. They have lost hope, they have lost the whole dignity, and they are completely useless. And most of them, from hearing from their stories, they have been abandoned. Their husbands have run away from them because they can't contain the urine. So it's a very, very sad situation. So as a center, we are also doing the prevention measures. We are providing treatment for those who have fistula, but we are also doing the prevention measures. We are very grateful to Rotary. They have already talked about it, that they sponsored the community nurse midwives and the nurse midwife training. That was part of fistula prevention. And the charity is also funding 3 healthy facilities, funding the maternity wing for access to quality maternal and neonatal health care. And we are seeing about 160 deliveries every week. We also use the radios to sensitize the masses, especially the community radios, because women with fistula come all the way from the rural areas. We are also doing the rehabilitation and reintegration. We don't just do the physical repair, but we also have to rehabilitate and reintegrate back into society these women. It's very important that we do that. This is so because they will be going back to the very same community that stigmatized them. So that's why we really have to take our time to really make sure that they should be willing to go back to the same facility. And the first one of the reintegration activities is the Patient Ambassador Program. This is a very unique program whereby we use survivors. We train them to understand what fistula is. We send them back into community to talk about fistula. And in turn, they mobilize patients, bring them to the center. This is our baby, especially the Fistula Care Center in Malawi. We started the program in March 2015, and we have recruited about 300 patient ambassadors. These are survivors, and some of them are guardians who are interested to help in identifying patients in the community. And 50% of our patients come through the patient ambassador. There are those who've brought 20, 30, 40, even 50 patients. They go around their communities, talk about fistula, introduce themselves, they have undergone the operation. By the end of the day, they mobilize the patient. We give them a t-shirt, a bag, a booklet which explains what fistula is. So in turn, we've seen that 50% of our patients annually are brought through the Patient Ambassador Project. And it's not only that, the Fistula Care Center has also a post-surgical rehabilitation program. This is very vital for our patients' recovery. So there are lots of activities that we carry out. We have the cooking classes to demonstrate how to cook healthy food on a low budget. Microfinance support. They have to open a bank account. We have to teach them business maths and also whatsoever we can manage, just to make sure as they do business, they're able to keep records, which we can see. They are able to balance. They are able to weigh how much am I doing? Am I making profit or not? There are also some income generating skills, like the solar power charging station project, the reusable sanitary pad project, and we also just introduced the poultry farming. The other thing also which is helping us a lot as a center are the ambulances, which were already mentioned. We are very grateful for the donation of these 2 ambulances since 2016. They are amazing. They have helped us quite a lot. We use them in community mobilization, community sensitization, referral of patients. We use them for screening of patients. We go on to outreach programs and do some screening. Right now at the center, we are doing the sewing machine training. And you know, the sewing machines are very baggy. So all what we're going to do starting from Sunday, the training is running for 7 days. This coming Sunday, we have to pick them using the ambulance just to drop them closer to where they are coming from to make sure they arrive home safely. We use them for emergencies. So these ambulances have really played a very greater role in terms of the fistula management as a center. Challenges. The fistula program in Malawi, for a long time, it's only the Freedom From Fistula Foundation that has come in. So it also lacks some donor support. We are very grateful to the Rotary Club, Lilongwe. That's the local one that have really also supported us in terms of the patient sensitization. And also Fistula itself is a costly program as it saves the poor, and the patients with fistula stay longer in hospital, not less than 3 weeks. Because after repair, they have to recuperate, that's another 2-3 weeks, and it also depends on the complexity. There are those who could even be in the ward for 1 month. And the other challenge is that there is high turnover of fistula-trained government employees. We've heard government has supported some clinical officers to train as fistula surgeons, but we've never seen any. So that's another challenge, that some of these clinical officers go and seek for green pastures. And fistula to me is such a very rewarding program that yields good results when you see the smile of treated patients. As a center, we have what we call a graduation program. When the patients are discharged, we organize a special ceremony where we also advise these patients on what they're supposed to do at home in order not to come back with a broken fistula, because that would be more difficult. When you see the smiles, the dances, and all of us dance, it's so beautiful. That's why I say fistula is a very rewarding program. And the victims of obstetric fistula, the survivors, those that have survived, represent those that have died in maternal days. So finally, I can say together, we can restore hope to the affected poor women. We can restore their dignity, maintain their human security, respect their rights, assist them to survive, support their livelihood, and save to change lives. These things, we can, all of us, do it in order to make life worth a living. Thanks so much, and thank you for your attention.
Hello, I'm Dr. Ened Chipungu. I'm an obstetrician and gynecologist, and at the moment working as a medical director for Waira Fistula Care Center. I joined Freedom From Fistula in 2013, and at that time I was a specialist, but I did not know how to operate on any fistula patient. So I've been trained and I've grown while I've been with Freedom From Fistula. I first went to Sierra Leone in 2015, where I went for a fistula camp. And I've worked in Aberdeen Women's Center again in 2018 to 2019. I was there for a year as the clinical director. And I've just returned from Sierra Leone, where I've been since January, and I came back here in July. The Aberdeen Women's Center is located in Freetown, which is the capital of Sierra Leone. And it started off as just a fistula treatment center when they took over from Mercyship. And throughout the years from when it opened in 2004, there have been over 5,000 surgeries done at Aberdeen Women's Center. At the moment, we do about 200 to 250 surgeries at the Aberdeen Women's Center. But as Margaret has talked about it, that fistula management is not just about treatment. It's not just about surgery. It's all about prevention, treatment, and also getting these patients back, reintegrating them back into the society. After seeing that we are just doing fistula, we also, they also decided to open the maternity center, which opened in 2010. And since then, they've done deliveries in over 30 women. At the moment, we do deliveries about 3,000 a year, about 300 to 350 a month at the moment. And it's such a rewarding process because you're seeing these women that they are booked with us, and therefore we see them from the beginning of their pregnancy, and we take them throughout the whole journey until they deliver. And we make sure they deliver safely and they go home with a live baby. Apart from that, there's also an outpatient clinic, which if these babies have a problem, because all women come from within the neighborhood, within the surroundings of the hospital, they can come back to the Aberdeen Women's Center for their children to be seen. And the clinic is open every day, Monday to Fridays, and we see children between 0 and 15 years. And in a year, we see over 30,000 children. And in a day, in the busiest of months, we can see up to 100 babies every day. And because we also still need to prevent fistula, there is also a family planning unit, which runs from Monday to Fridays. And in a day, we see about 50 women who are allowed to walk in without booking. So every time you feel like you need family planning advice or you are having complication with family planning, you can walk in and you'll be assisted. And on top of offering family planning services just at the center, we also do outreach clinics every Saturdays. So we go in places where they are highly populated, especially marketplaces or in the slums. And we do get women to come and get whatever family planning they wish to have. And also with the outpatient clinic, there are also some outpatient outreach clinics where we go to one of the slums called Force Bay, where these women are seen, Krube, where all the babies can come to the clinic, can be seen. And it's one of the satisfying things working in Aberdeen Women's Center, which is different from Malawi, because in Aberdeen Women's Center, you tend to see a wider range of clients, from mothers, babies, to family planning patients, and also fistula patients. Apart from this program, there is also a Dream Girls program, which is dedicated to the teenagers. So we do book all teenage pregnant women who come to the center, and they are booked into antenatal care. And during this time, they are taught how to look after themselves while they are pregnant, what they need to do when they go into labor, and they come and deliver with us safely so that they can go home with a live baby. And since this is also a high-risk group when it comes to fistula development, we make sure that they deliver safely and they don't get a fistula. And after they deliver, we still bring them back in to teach them some skills so that when they go back home, if they're willing to go back to school, they can go back to school. If they feel like they don't want to go back to school, they are taught some skills like home management, how to do laundry, how to look after house, how to cook, so that at the end of the day, they can get an employment, they can be employed and be self-reliant. We've also just started a new program where we're looking at victims of sexual and gender-based violence. So all clients from surrounding Aberdeen Women's Center, when they are victims of sexual and gender-based violence, they come to the center and they are seen by a clinician if there's anything urgent to be sorted out. And then they are seen by a counselor, and then we do refer them to centers where if they need to rescue homes if there's need. Otherwise, if they just need temporary accommodation, they do stay at the center for a while they're being counseled, and we're trying to get them back into the community. One thing which is different from Malawi is that most of our patients, they don't walk into the clinic. Is that every time we have to go into the community to go and get them, because most of them has never heard of Aberdeen Women's Center. They've never been to Freetown. They've had the problem, but they don't know where to go. Therefore, every month we send a team of nurses to go into the community where they talk to communities and they try and bring the patients back. And communication is kind of a problem in Sierra Leone. And even if you get a patient to the center, when they go back to the community, it's difficult to get hold of them just to find out how they're doing. And one of the programs which I think is also has not really developed nicely in Sierra Leone is the social reintegration. Because in Malawi, there's a solar program, there is the tailoring where they do pads, people can come and get trained in how to sew. In Sierra Leone, I think we haven't really gotten that far, where the focus when it comes to fistula management is just on surgery, and I think we need to do more. And what is worrying at the moment is that we're still seeing more and more fistula patients, and these are not old fistula patients. These are new patients. It means that maybe as a community, maybe as governments, we're still not doing enough to prevent fistula, because in this day and age, we shouldn't be seeing new patients with fistula. At the moment, our emphasis is in Freetown, which is the capital. Maybe we need to try and develop more and maybe get into the community more, try to get to these women, especially in areas where we're getting lots of these fistula patients. And what hurts the most is that when a fistula patient comes, you treat them, they go back to the village, and then next year you see them coming again after delivered a baby, and they've had another fistula. And at Aberdeen Women's Center, one of the benefits is that after they've had the fistula repair, once they are pregnant, they are allowed to come back, to wait at the Aberdeen Women's Center and deliver their baby there. But as I've said, because most of them are coming from very hard to reach area, they don't even have transport money to come back to the center. And it can be worrying that they go back and they come back with the fistula. So in a nutshell, that's Aberdeen Women's Center. It's not just about management of fistula. It's, as Lois has said, it's more about maternal and child health. And it does look at a woman as a whole, starting from her to her children, and also to all the young girls, the teenagers. Thank you very much.
Well, Margaret and Ennett and Lois as well, I'm sure I speak for us all when I thank you for that wonderful overview, that wonderful insight of the work that you're doing. And, you know, as I sit here in the borders in Scotland and think we're connecting live with people in Malawi, we're all getting a bit zoomed out, I think, but it's one of the wonderful things that has happened as a result of this current crisis. The technology allows us to be meeting you live this evening from Malawi, whether we're in Scotland or in England or in the USA or in Indonesia. There's people from all over the world here listening to you and hearing from you as to how exactly things are on the ground. Thank you for sharing with us this evening, but more importantly, thank you for the work you are doing there and the wonderful work you've done and the work that you will do in the future. It's now my great pleasure to introduce Jo Pauley from the Rotary Club of Eyemouth, and herself a past district governor here in District 1020. Jo's been very involved with Freedom From Fistula over the last couple of years or so, and among other things, she's going to tell us why she got involved in the first place, and also just what might be possible in the future. So Jo, it's over to you.
Thanks, Gordon, and thank you all for attending tonight. It's tonight here in Scotland. Maternal and child health is one of Rotary's areas of focus, and it's wonderful to be able to see the journey that women and girls take following their fistula surgeries towards being dry and reintegrated into their communities. And it's been fabulous to hear from Margaret and Dr. Ennett. Freedom From Fistula's holistic approach ensures that fistula surgery is just the first step to a life worth living. Gordon has already mentioned the World Health Authority's figures, and indeed Margaret and Dr. Ennett have mentioned the horrifying statistics of women and girls that are suffering from fistula across the world, and in particular Malawi, Sierra Leone and Madagascar. Rotarians from across the world have worked in partnership with Freedom From Fistula for many years, with truly life-changing outcomes, giving a future to many where perhaps previously there was little hope of regaining dignity and inclusion, let alone having the skills to earn a living. This truly empowers women and girls so that they are no longer frightened, alone, ostracized, and suffering in silence. But moving forward, we can do even more. And I'm hoping that there is a couple of slides that you're seeing. Here we go. Thank you very much. There's a couple of slides that you can see in a moment, one of which is the patient's journey to freedom that gives you the story from screening from surgery to returning home healed and dry. The second slide is showing the holistic approach, all the other things that Dr. Ennett has mentioned that Freedom From Fistula do to help the women and girls reintegrate into their societies and also earn a living and giving them their dignity back. But moving forward, we can do even more. And on the next slide, this shows some of the things that we can do to help make a life worth living. From as little as £2, you can help feed a fistula patient a day during their stay. £5 funds a consultation at the outpatient clinic in the Aberdeen Women's Centre in Freetown. £50 helps educate the fistula patient after surgery, providing literacy, numeracy and vocational lessons. But £50 would also pay for a sewing machine and material to enable a fistula patient in Malawi to start her own business, producing, for example, reusable sanitary pads when she goes home. £100 would provide support for safe birth for mum and baby. £500 helps to provide a fistula surgery and rehabilitation, restoring dignity and offer hope for the future for a life worth living. And £8,500 would fund the entire patient ambassador programme in Malawi for 1 year. That may sound like a lot of money, but people working together can make a difference. And working together with other community groups close to us, we can make a real difference to vulnerable women, girls, and children across Africa. Rotary International's vision statement is "Together we see a world where people unite and take action to create lasting change across the globe, in our communities and in ourselves. Together, how many more lives can we save and transform? How many more lives can we make worth living? How many more women and girls can we empower? This is the power of Rotary. This is the power of working in partnership. Thanks, Gordon.
And thank you, Jo. Thank you very much indeed. I think we can all sense your passion for this project, and I'm sure we can all see the value in scaling up Rotary's involvement with this particular project. Friends, I'm sure much of what you've heard this evening has prompted you to think of questions. And although we have only a very few minutes left, please feel free to put your questions in the chat box, and we will try to answer as many as possible here and now. What I would like to assure you is that if you get your question in the chat box and we don't get round to taking it tonight, then we will get that answer to you within a matter of days from the Freedom From Fistula or indeed the Rotary team, because I'm delighted at this point to be able to welcome to the seminar past District Governor Alan McLaughlin, who is Mr. Foundation in District 1020, and what Alan doesn't know about Foundation is not worth knowing. So I'd actually like to put the very first question to Alan, and Alan, if you'd like to unmute yourself, and I wonder if you could maybe just tell us, who does a Rotary Club contact within Rotary Great Britain and Ireland to get grant funding information?
Good evening, Gordon, and everyone else. Quite simply, contact your district team. As Rotarians, in your districts, you should have a foundation team. If you don't have a foundation team you can identify with, you have your governor, your secretary. Please get in touch with them and they can pass the information upwards and onwards or distribute it. Once the information is received, the foundation team, if I speak of what we do here in District 1020, can then find the appropriate channel to get help to you wherever you are, whether it's giving you information, whether it's helping you fill in pro forma. But everyone, there's always someone there willing and able to help.
Thank you, Alan. Maybe a quick supplementary before we go to a question for Lois and the African team. Is there a minimum amount a club can contribute to a grant project?
Well, we're talking about two types of grants, Gordon. There's a global grant and there's the district grants. So district grants can be used to fund small projects round about working directly with a charity group. Global grants, they're a minimum of $30,000. So there, what we're looking for is clubs and districts to come together. You don't have to just work with clubs in your own district. You can reach out to neighbouring districts and fund a grant project in that way. It has to be led by a single district, but the supporting districts can provide admin support and financial and moral support.
That's great. Thanks very much. And I wonder if I could turn now to Lois and the African team. And I wonder, Lois, if you or Margaret or indeed Enid could tell us how important is the rehabilitation and reintegration process for fistula patients after they've completed their surgery?
Thank you, Gordon. I think probably Margaret's the best person to answer this. However, I will quickly say that the highlights of my entire time working in Freedom From Fistula have been two. One has been any time I've had the chance to go back to visit a former patient in her village when she's built up a little business for herself using some of the rehabilitation skills she's received in our centre in Malawi, and that's just phenomenal to see. And the second point is when you see a former fistula patient having her baby born safely in the maternity unit of the Aberdeen Women's Centre in Sierra Leone through having had a successful C-section. So I'm going to ask Margaret, though, to step in and just really try, Margaret, and maybe you could use one of the patient stories as an example of how important it is, the rehabilitation for them.
It is very important that we rehabilitate these patients back into society with confidence. It's just because after repair, they will be going back to the very same community where they were stigmatized, ostracized. They were never counted in society. So all what we are trying to do when they are at the center is to make sure we bring back their lost dignity, lost self-esteem. So after repair, we really sit down with them to understand they have healed, they are no longer leaking, they are ready to go back to a society and resume their normal duties. They become so happy and so excited. And most of the time, they don't even believe it has happened that they are dry, because when they were in the society, it was news. Everyone talks about them and they don't even count on them because most of them, the baby is dead. And in Africa, when you don't have a baby, it's very difficult to be recognized in the community. So that's why part of rehabilitation is to build back their confidence. And as a facility, that's why we also involve the former patients as part of our domestic team. They play a very important role. They are our models. They sit down with everybody who comes to the center. They are our models because they say, look at me. I have fistula for 15 years, 18 years. I'm cured. I'm able to work. I can integrate with anybody. I can go to church. I can go to weddings. I can go anywhere. So that in itself builds confidence. And by the end of the day, they go back home with confidence. That's why within the very same community where they were being stigmatized, they are able to stand up, advocate, talk about fistula, mobilize patients, and bring them back to the center. Dr. Enid, maybe you want to add something?
No, I think Margaret has covered it all.
Thank you very much, Margaret. Friends, unfortunately, as happens so often on occasions like this, time has beaten us. And I'm afraid we're going to have to begin to draw this evening's webinar to a conclusion. But what a wonderful way to draw it to a conclusion and have Margaret there with that wonderful answer to that question. It's interesting, I've noticed a couple of comments popping up in the chat as we've gone on this evening. And one is a comment from Sakshi Pandit, who has said, it's a brilliant act of service which is uplifting hope and lending medical support. And indeed, that's exactly what it is doing. And Janine Birtwistle from Guernsey, who had to leave us a little while ago because of technical problems she was having, has said, such an essential service by an amazing charity. And the Rotary engagement with this is really important. It ties in so much with empowering girls. And as I said earlier, that is exactly what we are being asked to do this year in Rotary. So can I now begin to draw this evening to a close and thank each of our presenters, particularly Margaret and Ennett over there in Malawi, as well as our technology expert, Callan Dick, who's been beavering away backstage, not just for the last hour, but for considerably longer than that. Can I thank each and every one of you for giving up your valuable time this evening to be with us. We appreciate it very much indeed. For those of you who already support the work of Freedom from Fistula, I hope this has inspired you to support it even more. And for those of you who are maybe hearing something of it for the first time this evening, I hope you will consider supporting it going forward. We'd like to close with another short video, a video of the Gladdy Gladdy ceremony, which is a celebration. As Margaret described it, it's a graduation that's held as people leave the clinics after treatment, ready once again to take their place within their community, within society. It's symbolic of hope for the future, and it shows how working together We can make this happen. Thanks for being with us this evening. Good night.
Finally, it is the day of the Gladi Gladi ceremony. All the women's trials and all their difficulties are momentarily forgotten.
We make each woman an outfit for what we call Gladi Gladi Day. It's the day they go home. So it's like this is them moving from their old life to their new life. It's a very emotional day for everybody.
It's a way for them to thank all the staff and us to say goodbye to them properly.
They will dance with you, beat some drums.
Do gives any other patients that have not gone through the surgery, do gives them hope. That's Gladi Gladi.
What makes me Gladi Gladi is seeing these girls, seeing these patients completely transformed.
To know that I can add in some small way to the end result, that there is a Gladi Gladi at the end, that is the most phenomenal thing.
Shout Gladi Gladi.